Hello, and welcome to the Pharmaphorum Digital Innovators series. I'm your host, Jonah Comstock, Editor-in-Chief at Pharmaphorum. I'm joined today by Amy Bucher. She's the Chief Behavioral Officer at Lirio and the author of Engaged, Designing for Behavior Change. Welcome to the show, Amy.
Thanks so much. I'm really excited to talk to you today.
So, Amy, you have a somewhat of a background in pharma among a much larger healthcare background, but it's always been around this sort of focal point of behavior change in healthcare and healthcare design, right?
Yes, absolutely. So I have worked with pharma and in pharma in a variety of roles, but as you said, always focused on behavior science and applying that to helping primarily patients, sometimes providers, adjust their behaviors to maximize their response to whatever pharma is offering. Because we know that as much as a pharmaceutical product can, really be a miracle, oftentimes it does need the patient to take some action to maximize its effect. So I have worked with pharma companies as my clients, building solutions that support patients through behavior change and help to engage them in that process. And I was also an employee of Johnson & Johnson for a number of years. So working within the J&J organization with Janssen and with some of their other operating companies to do that same sort of work.
So we talk a lot, I think, in this industry about patient engagement and patient sort of activation. We talk certainly about design. We don't talk about behavior change, I think, as much as we probably should, even though all those things are kind of intrinsically linked. So I wonder, just to start, can you sort of talk a little bit about how behavior change sort of fits into all these other conversations we're having right now in pharma, especially around marketing and communications?
Yeah, and it's interesting because even as you say patient activation, I mean, there's always this implicit part of it, which is, of course, like activating means that you're doing something, but you're right, we don't always talk about it in terms of the behavior. What we do often talk about are things, and especially with patient activation, knowledge and motivation. One of the definitions of motivation that I use a lot, which I have shamelessly borrowed from Scott Rigby, who is another psychologist working in the motivation space, is that motivation is desire with velocity. And if you remember, like your high school physics, velocity is speed in a direction. So there's an object of motivation. There is a behavior attached to motivation. And when I think about what people need to do to achieve a health goal, I really think about it in terms of let's being really crystal clear what those behaviors are. I'll often refer to them as target behaviors. And then let's back out and understand like what makes these behaviors difficult for people, what makes these behaviors easier when they do occur, and how can we, as we're designing a patient engagement solution, for example, really clear away as many of those barriers as possible, whether it's providing solutions that actually solve for them or talking to patients in a way that helps them to see those things as less of a barrier. And if there's something that's already working in the favor of that behavior, how do we capitalize on that? How do we build that into our solution or make sure that that's a considered part of the environment? And I think that focus on behavior allows us to do a much better job with engagement, with activation. So I'm really glad to be having this conversation and bringing the focus back onto it.
So in your experience in the pharma world, both working there and since then working with clients, we're seeing it. How do we do at using some of these ideas, and how could we do better?
Yeah, I mean, I think that it's a real mixed bag. I've definitely seen some great success stories, and I've also seen some places with need for improvement. And I think where we fall down oftentimes is just in a complex ecosystem, it can be really difficult to elevate that focus on behavior above other concerns, which is really natural. And then a tension that I've experienced personally over and over in my career is the way that businesses in the United States are organized. We're really focused on short-term outcomes and short-term returns. Even things like reporting our quarterly outcomes. And behaviors can take a really long time to change. It's one of those situations where, we're all people, you have habits, you have ways of being, and we're all ensconced in an environment that really affects the way that we behave. And it can take a lot of time to change that environment. Even things like getting a healthcare appointment on the books. In my current role in the research that we do with some organizations, we're seeing patients having to wait months before they can see a provider for certain types of procedures. And if we're putting out a behavior change intervention that is focused on visiting a provider, and there's a 3 or 4 month wait for that, I mean, naturally, we're not going to show any positive results in 1 quarter. So that's been a really difficult dynamic to work with. And it's one of the reasons why I've focused a lot on how can we frame some leading indicators around these. Are there stories we can tell right off the bat, whether it's through patient research where we're getting people to tell us their stories, and we're kind of producing that qualitative information that suggests that we're on the right track, or even focusing on things like engagement with a digital intervention. As much as I don't want that to be the whole story, sometimes that needs to be the right now story while we're waiting for that longer result to play out.
Right.
So that's been a real challenge.
So motivation is only one piece of the puzzle. If you motivate people to do something that you haven't, created a capacity for them to do, then you've really just made the experience about as frustrating as you can, right?
Right. Oh, totally. I mean, and I was surprised. I did an interview a couple of years ago, and I was heated, and I was surprised I got quoted quite a bit after this. But I said something like, "You can't motivate people out of poverty." Because in certain spaces, you really see that. I know there's some legislation right now around the cost of insulin. And a thing we see often with diabetes is people will make a deliberate decision to use less insulin or test their blood sugar less frequently because the finances aren't there for them. And that's not a question of motivation at all. They may very much want to do the right thing, but they're balancing competing needs, and they don't have the resources to do that. So,
and at that point, we start to sound very tone deaf when we talk about behavior change and motivation,
right.
When the real problem is that they just can't afford this,
Right. Yeah.
You mentioned digital interventions before as something that, sometimes that's what you're moving people towards, but you don't want it to be the whole picture, the whole story. I actually wanted to get into that too, because I think when we talk about innovation in pharma, in any industry right now, that their tendency is to immediately go to technology, right? Like innovation is using digital technology better. It's being more online. It's, using the metaverse or VR or whatever. One of the things I like about the behavior change framework is it I think separates those things a little bit. We can innovate in a lot of ways with the technology we have, even technology we've had for a long time. But how do you, in your work, so how do you look at technology and the role that it should play and shouldn't play?
Yeah, it's funny that you asked that, because my career has been almost entirely within digital health. So I really have focused on digital technology, but I'm interested in digital as a way to scale what we're able to offer with some of the lower tech or more old school approaches. So it remains true, for example, that for many people, their physician or their healthcare provider is the most trusted individual when it comes to health advice. And so a recommendation from that person is going to carry much more weight than anything that comes through a digital intervention. But one of the things that we also see, high touch human contact is not scalable the way that digital is. And there are a limited number of providers, a limited number of resources, and they can be much more difficult to access. So the more that we can use technology to bridge to those lower tech, higher touch, intensive resources, I think the more successful we can be. I really think of it as, how do we pull out and look at the system and start to understand where are the places where we absolutely need to rely on the high touch approach, and how can we use technology to support, augment, offload, but in a way that really makes sense. So, whether it's what we do at Lirio, for example, we're using technology to identify people who are recommended for healthcare. And of course, we're not doing the healthcare ourselves. We're sending them to their doctor or to their provider system to receive the preventative exams, whatever it is that they're recommended for. But we can certainly offload something from the system in terms of doing that outreach and getting in contact with the patient, and speaking to them in a way that's really compelling about why they might want to take these actions. So I agree with you. I think technology shouldn't be used for its own sake. I think it really needs to be examined as a tool, as a means to an end. And oftentimes the answer is not going to lie within technology. It might be, how does technology support something else?
One of the big, I would say, motivation gaps that pharma specifically deals with when it comes to patients or individuals in the healthcare system, health consumers, however you want to sort of nomenclature that is around clinical trials, right? There's so many trials that need participants there, and in many cases, the trial is probably better for the participant than the status quo of the drugs, but making that connection, making people aware of their options, that's always like a really hard problem that pharma deals with. And so I wonder, using this behavior change lens, looking at this motivation lens, what are some of your thoughts about how we should be approaching that?
Yeah, and I've been thinking a lot about this, both recently and over the course of my career, because as you said, it's just one of those thorny problems that continues to recur, and clinical trials are so vital to advancing what we do in pharma. So, I mean, one of the things, again, that I always go back to is what are we really asking people to do in terms of behaviors, and how do we start to understand what some of those barriers and benefits are in a way where we can hopefully address the barriers and frame things in a way that aligns with what motivates people. So, people are bringing their own values, their own sense of self into these conversations. And if we can frame things in a way that resonates with that, they are more likely to be interested and to work with us in moving toward the behavior. I think clinical trials are interesting because the physician or the provider is also a player in that conversation in a bigger way than with other health behaviors, because oftentimes, again, the provider being such a trusted resource to the patient, the recommendation for the trial or the information about the trial may be coming through that person. And so that's another individual who really needs to be influenced and understand, why would you want to bring this up to your patient? I am less knowledgeable about the cost and benefits for the physician side, but I know from the patient side, we're often asking them to go into an uncertain situation. And, we don't know with some of these, well, the purpose of a clinical trial, it's a research study. We have a null hypothesis that the treatment may not be effective. And so expressing that in a way that is consistent with human subjects research practices to patients, I mean, that already introduces a hurdle to overcome. But what I've seen people respond well to is understanding what it might offer them in terms of a treatment. And especially if we can tie that back to quality of life, if we can reduce your symptoms, if you're in pain, if we can reduce that, if we can make you able to participate in something that you really value, and also the benefit that it gives to other patients, the more that we can kind of magnify that. And I just will say, I recently had the opportunity to tour a clinical trial facility, which was absolutely amazing. But it did strike me that it's oftentimes a huge ask of patients to come spend a week or a month in this facility, depending on what the study is. So I mean, just being really recognizing that we really are asking a very big thing of people, and so that conversation really needs to be done in an incredibly respectful way.
It's kind of a tightrope or a balance beam where on the one hand, you don't want to, undersell the fact that it is experimental and that you don't know what'll happen, but you also don't want to, you don't want people walking away saying, I'm not going to be a guinea pig. I don't want to, in fact, by the time you get to human trials, a lot of work has been done. There are, controls on the risk you're exposing people to. So it's not an easy thing to convey exactly what you're asking of them and where that risk level is.
No, it's not. And not even for people who have a background in this stuff. So, for example, anybody who has a research degree like myself, I have continually gone through human subjects research training. I'm recertified every single year in my role. And even so, it's sort of impressive to me every time I redo that training to understand the level of research that has gone in prior to human trials to communicate something like that takes someone, with my level of education, some time to grasp, to somebody who doesn't have that background, is a real challenge.
So I think we're coming to the end of our time. I want to ask one more question. Your book is Designing for Behavior Change, and we haven't talked so much yet about design and how that fits into, the story with technology, behavior change, care systems. So, I know I'm asking you to give me your whole thesis in a very short package, but tell me a little bit about that piece and how people should think about design.
Yeah. And, we've talked about it more than you maybe think, because one of the first steps is really identifying the behaviors that we want people to engage in and working backwards from there to understand the barriers that they might experience, any facilitators that are helping them to do that behavior already. And then identifying the right interventions or approaches that amplify the facilitators and overcome the barriers The other big piece of it, though, is really being clear at the outset on what kinds of outcomes you hope to achieve, and mapping those out. So this gets back to what I said as well about the focus on kind of short-term returns. One of the first things that I do in any design endeavor is map out the outcomes, and I do it over a time scale. So, if we've ended this project and we're looking back, what does success look like? And frequently that's going to be something like an ROI. It's going to be, a reduction in disease burden or symptoms. It's going to be kind of these long-term outcomes that take some time to achieve and are really meaningful on both an individual and a system level. But working back from there, we should be able to see changes in people's behaviors, and that should be something we're able to measure. And even before that, if it is a digital health intervention, we should be able to measure, are people using it? And we know, people need to use it in order for any other outcomes to happen. So if we can map out these outcomes along the way, it helps us to tell that success story from a very early point and be confident that we will ultimately arrive at those bigger, more meaningful results. And it also keeps us honest in the design process. In mapping out what we hope to achieve, it forces us to think about, what does this intervention actually have to do? What behaviors do people actually have to change? So if there's one thing about behavior design that's really important, it's mapping out the outcomes.
Thank you so much, Amy. Any final thoughts, or, talking to our audience as pharma execs, folks involved in that, any parting words that you might have for folks as they think about how this stuff might apply to their own day-to-day work?
Yeah, I would say, in my experience, I found that oftentimes in pharma, if you have not worked with behavior science or even with user research, user experience research in the past, it can feel a little conceptual, and you're not sure what the benefit it would bring. And I would really encourage you to do a project, hire somebody to do some user experience research, gather some patient insights, and as much as possible, be present for that firsthand. Most organizations that do this sort of research will let you, watch behind the one-way mirror or on a Zoom. And there's no substitute for seeing firsthand what the patient experience is like. And I truly believe it is life-changing if you're working in part of the healthcare industry where you don't have exposure to that. And it starts to open this understanding of why it is important to think about behavior science and patient experience in this really hands-on type of way. So the more that I can get people to dip their toe in these waters, the more I would consider my job to be done. So that's my advice.
Awesome. Thank you so much. And thanks so much for joining me today. I'm so glad we got to have this conversation.
Me too.